It was so lovely. So I would like to introduce our next speaker, and he is going to be speaking on finding a civilized balance, empowering patients to manage their care. So Dr. Athol Wells grew up and trained in New Zealand, but has spent over half his life in the UK and is a citizen of London. His current post is Professor of Respiratory Medicine at Royal Brompton Hospital. He works as an interstitial lung disease clinician with parallel interests in sarcoidosis and fibrotic interstitial lung disease. He has participated in guideline development and vast amounts of research in lung health. Dr. Wells has been a member of the Fleischner Society since 2007. He is the current president of WASOG, the World Association for Sarcoidosis and Other Granulomatous Disorders. Dr. Wells.
I don't know about you, but that introduction sure frightened me. Okay, so I've got to speak about a civilized balance, and I think what I'm going to do first of all is to ask you a question, giving you the context, and the answer will tell me actually whether what I'm going to say is mostly obvious to you, in which case I can speed through and we can have a lot of fun and discussion, or whether I should be developing themes a bit more slowly. Okay, so this is a leading question, I think a lawyer would say. Medical care. We're going to talk about management, but it also includes diagnostic tests, and you've all heard this mantra, you should have histologic proof of sarcoidosis. But often the diagnosis is obvious, or fairly obvious, without an uncivilized test such as a bronchoscopy. Maybe the scan is such that a good radiologist is saying, no other diagnosis is plausible. And let me set the scenes. When we think about diagnosis, we're thinking about likelihoods. So a diagnosis might be established. It's never 100%, by the way. That's a chimera. But 95%, and we're not exact with numbers. Maybe a diagnosis is just about there, not quite, but so close that the only logical approach is to manage for it. Maybe it's more tentative. It's more likely than not, but you're in doubt. And if you can't make a diagnosis more likely than not, you view the problem as unclassifiable. Now, I like this analogy. It's the Cheshire Cat. If you don't know where you are going, any road will get you there. So, this is an established diagnosis. This is a provisional diagnosis, a working diagnosis. If you can see a lot of the cat, you're quite confident. And the next one is unclassifiable disease, and I show this for a very deliberate reason. If anyone asks an uncivilized question, this cat is coming for you. So this is my question. If a biopsy decision is a very close call, and I want you to think back. I want you to think back to the time that sarcoid was raised. Would you prefer that your doctor simply told you, you need a biopsy, have a biopsy? Would you prefer that the doctor told you that the decision is a very close call and asked you to consider the pros and cons of a biopsy and take part in the decision? Show of hands for option 1. Show of hands for option 2. Look, this audience is going to favour option 2, just by the nature of who you are. I was at a lunch table today, and it became fairly obvious there's going to be a lot of people here who have professorships in being patients, basically. Actually, they made a really neat offer. If I make a joke, I should scratch the left side of my face, and they promised to laugh. So basically, for the majority of you, quite a bit of what I say may be obvious, but then that makes you influencers, and I think I'm still going to spell stuff out. Okay, the issue is participating. And for a biopsy, I don't think it's a bad decision in the scenario that I've mentioned for you to have a biopsy. I don't think it's a bad decision not to. You can decide not to, and you can then look at the behavior of it and just check that it's behaving in the right way, and then go back to a biopsy if something odd is happening. So you know they're both right answers. For management, failure of participation delivers bad management, and that's my theme. And what you would say is, if a decision is 50-50 medically, and believe me, it often is, however confident doctors might seem, but the patient has a strong view, it's not 50-50 anymore, and the doctor should support the decision. So in this spirit, let's think about barriers to optimal management. I had to develop this ethos around the time of the millennium. And I have to say that in some circles, some of it went down like a lead balloon, but let's just talk our way through this. It became obvious, and this is one of the things in a referral centre, and I'm talking about maybe before the millennium, that an awful lot of patients were unhappy. Basically, there was a lack of understanding of why am I having treatment. And then there were these opposing concerns. Punitive steroid regimens. If you had a problem with quality of life, it's not exactly a therapeutic triumph if the drug you're using has a net effect in reducing your quality of life. And then there was the concern, especially at that time, that maybe steroid therapy was a somewhat nihilistic approach. Well, let's go beyond that. Why the issue? And is it surprising, and I saw this all the time, people voted with their feet. They didn't understand why they were being given therapies, what the exact goals were. They had side effects. They stopped the therapies. They stopped coming to follow-up. And what we lacked was a simple algorithm, persuasive, logical, immediately understood, and giving a basis for genuine partnerships between patients and doctors. And this was the core of the problem. When should you start therapy? And there was a cloud of confusion. You look at medical textbooks, you go online, you will find at that time long lists of reasons to treat. Go to each organ, find a symptom, spell out the symptom. We wanted logic, and there might be 40 reasons to treat, but there sure aren't 40 logics. And so the exact big picture goals, what were you trying to achieve? They were not being deconstructed. And in the end, what does anyone want from a doctor? Well, they would like to live longer and they would like to feel better. Now, admittedly, one or another person might want help in assessment to work. They might want help in advice to family. But what is uniform to people are those two things. And therefore, the goals of treatment had to be, in those patients at risk of dying from sarcoid, to address danger, and in others, to address unacceptable loss of quality of life. And so basically the algorithm developed when you met somebody for the first time. You were working out two things. Was there danger? And by danger, I mean both a risk of dying from sarcoid, but also danger of permanent disability developing, going blind, being disabled by breathlessness. If you did not have danger, was there unacceptable loss of quality of life? And it became very clear, as soon as sarcoid was described, that these two things did not go hand in hand. And look, which goal you're addressing has the most profound effect on your treatment approach, your monitoring, and on doctor-patient interactions. So what became a rule for me was to say this as soon as somebody walked through the door, and you'd exchanged a few facts, you'd exchanged some jokes, and you got into the heart of the matter. Why treat? You said you were going to identify danger with initial tests, and you slightly apologetically said you should be aware I may be forced to make strong recommendations, but you were asking patients to think about their quality of life in the next 3 to 4 weeks before they came back to see you. And this was preparation for patient empowerment. So in the next 3 to 4 weeks, think about how you feel every day, and especially think about whether you're convinced you need an intervention. Some people will accept some symptoms because nothing like a little light music. But I'm not going to dance, I will promise you that. But some people don't want therapy, and provided they understand there isn't danger, that liberates them to think about that decision. And basically, if there's no danger and there's no unacceptable loss of quality of life, the default option is mycotherapy. Do you know mycotherapy? Masterful inactivity with cat-like observation. The role of the doctor is to amuse the patient while nature takes its course. But look, some people get offended by masterful inactivity because they've had bad masterful inactivity. They should have had things done and they haven't. And what I'm saying is, don't try that without the cat-like observation. If you think that's the right approach, come back and make sure you're right about that. So knowledge is power, and so is clarity of thought. And simply, I found immediately, a lot of my patients had no idea whether they had danger, and a lot of them had gone online. They'd read nasty series about nasty disease. They couldn't think straight about quality of life because they were looking at a bright, dazzling light, the question of danger. So simply laying on the line as you could in the majority of people, that their situation didn't seem dangerous, but you were going to check some tests to be sure, and the majority of people were in that position. By saying that, you got an immediate liberation on the spot. And then people were thinking seriously for the first time, if there's no danger, do I want therapy? And this was a key question for me. If you could get rid of one symptom, what would that be? And you ask yourselves, but I won't ask you to answer, what do you think the most frequent answer is to that question? And the answer is fatigue. And I would say half my patients, provided they knew that it wasn't shameful to admit to fatigue. Now what then transpired, you've got to de-shame fatigue. People have had it from their families. They've had it from their local doctor. Fatigue isn't understood. You look well. It's all in your mind. And a failure to acknowledge that this is part and parcel of having sarcoidosis. I didn't think I'd ever use this phrase, but COVID has been helpful, because COVID has persuaded us that fatigue is bona fide. Brain fog is bona fide. Immune upset in all sorts of settings, gives us fatigue, gives us brain fog. But sarcoid is remarkably similar to long COVID. A high frequency of both things, a much less frequency of really dangerous organ involvement. So as I said, all of this, it's very careful preparation for patient empowerment, and no doctor should ever assume, however people are presenting themselves, that there aren't empowerment issues. And how decisions might be reached, I really have always felt you should discuss that the first time you see somebody. And this also applies to future decisions related to danger, and indeed, a number of people with danger also have loss of quality of life, and some of their symptoms, some of their treatments aren't about danger, they're about the quality of life. Gabapentin in neurosarcoid isn't actually treating and suppressing the sarcoid itself, it's addressing loss of quality of life. So the principles I'm about to espouse, I can say them more clearly if we're talking about just loss of quality of life, but patient empowerment also belongs when there are quality of life issues with danger. So we've got two broad patient-doctor dynamics. The evaluation of whether a treatment is needed for danger, and I could take you over the panoply of scenarios where there might be danger. It's been estimated maybe 30% of people with sarcoid have major organ involvement, but some of the major organ involvement is relatively mild and stable, so danger in a lesser percentage, loss of quality of life far more prevalent. And I don't want to say much more about dangerous disease. I do believe that empowerment issues are important, and I like to be a bit apologetic that I'm strongly recommending treatment for danger reasons, so I don't get into a hang-up where a patient has had over-authoritarian statements in the past. So evaluation of loss of quality of life, it's a package. You don't go to separate organ involvements and quality of life. You sum it up. You look at everything that the patient is describing. You get what matters most to them, fatigue, but you get two or three things that matter a lot, but you've got to go through everything they're describing. And then you think about management, and when it comes to quality of life, there is no single correct regimen in sarcoid. It's untreatable with an inflexible management protocol. All of the standard approaches you read about are actually written for danger. So when it comes to treating quality of life, I will make 15 different deals with 50 different patients, basically. Tried to put that in the BTS statement, actually, but the reviewers came back and said this was too colloquial, so wasn't allowed to say this. Had to change the wording. Now, this is the problem that you've got to confront. And actually, it may not be helpful for you, but it's helpful for any young doctor. Some of you here wanted the doctor to make the judgment. They didn't want involvement in a decision. This is more frequent in more general people with sarcoid. Sometimes culturally, people don't like always being invited to take part in medical decisions. And there's nothing more devastating to a younger doctor than to do all this all correctly and then say, the patient says abruptly, "You're the doctor." And really you're saying you're sitting on the fence, you're frightened of making a decision. They don't say that to me because I'm old and ugly. And I think they have a sense that I am sitting on the fence, but I do say to people, for heaven's sake at the start, tell people that if they really want you to play God, then of course you'll do that. You will make a decision for them. But actually any decision that you choose, that you want me to make, is going to be a much, much better decision if you actually are able to take a view. So lay that on the line. Okay, let's go into a little more detail. Quality of life, I've said, radically different approach. I can't come to a patient and do a blood test and declare they have 17.717 units of fatigue, can I? There's only one world expert in the room on the impact of fatigue on the patient, and that is the patient. So in the end, the casting vote on what you might choose to do requires very careful education on downsides and potential advantages, but people need to buy into what you're suggesting, and they also need to understand that sometimes you have to shop around different drugs. You won't always hit the mark first time, and you've got to find a therapy that suits the patient and gives you the right benefits without major loss of quality of life. And if you don't do that, if you don't go through that, you will deliver bad management, in my view. You're discussing benefits and side effects. You're promoting a patient-led risk-benefit decision. And don't tell me that people don't understand risk-benefit. Of course they do. The huge majority of people do. It's patronizing to imagine otherwise. So I said 15 different deals with 50 different patients. The initial treatment is negotiable. Some people have steroid phobias. Maybe their family members have been poisoned by steroids, I mean. The starting dose is negotiable. I think it's nice to give somebody a short burst of, say, prednisolone 20 milligrams daily, because you're establishing maybe that a steroid approach is likely to be beneficial. You're also getting a more rapid effect, but you bring the dose down, in my view, for quality of life really quite quickly. And you talk people through a hit list of therapies, which therapies tend to be more civilized, which therapies might on average be nastier. And the way you continue treatment is negotiable. Now, what is the problem here? I don't see one. With giving patients a supply of low-dose therapy, say a supply of prednisolone at 2.5 milligram doses, and inviting them to experiment, work out what low dose gives them the best benefit for the least side effects. Why not? What is the problem with that? What is the problem with a patient who knows this best, understanding the nature of their sarcoid and deciding, look, a lot of the time I'm fine, I will have these flares. I feel that when I have a flare, that's when I need a course of prednisolone, and then I'll come off. I have any number of patients who actually find that that's a reasonable approach. Sometimes they're using steroids so often that you have to talk to them about actually, you'll probably use less if you go to a low-dose chronic therapy rather than needing higher dose bursts every now and then. And the other thing you have to do is understand that people actually know when their sarcoid's active. Sometimes it's hard to put into words, isn't it? But you just know how it feels to have active sarcoid. You know that you have got a flare. You should be listened to, because that actually should influence what is done. You should be empowered to put that information into your management. Civilized balance. Now, I'm making it sound that you all walk into a doctor's office and tell them what to do. And that is not the case, and I really have to say that, because often an assumption is made that every symptom is due to sarcoid, and very often a major symptom is not. Now, I've sat for some years in the same room as a neurologist, seeing people who were supposed to have neurosarcoid. The majority did not. And the common misconceptions were migraine, often atypical, and then, say, a pinched nerve somewhere, or some other source of pain that had nothing to do with sarcoid. Now, I don't think steroid and methotrexate has good therapy for migraines. And so you actually do need that medical expertise to work out, is the symptom sarcoidosis? Now, I'm getting towards the end, I believe. I can see 6 slides to go, and I'm just going to see how much time I have used. Yes, I think that's acceptable so far, but we're going to have time for discussion. I'm going to come back to fatigue, but I'm going to skip the next 2 slides, which is about understanding fatigue. You need to do that in order to properly address it, but we can come back to it if you would like me to. And I'm going to talk about empowering patients, and I'm going to say from the start that fatigue is terribly frustrating because a lot of the standard therapies don't work. So anything you can do to empower people to take control of fatigue has got to be incredibly helpful. Fatigue diaries. So you're asking people to work out what activities drain them, and especially who are the people they deal with that are energy drainers. Now, I can tell you in the UK, what I get is mothers-in-law, very commonly. They're energy drainers. But what you're trying to establish is the pattern of fatigue and what you can do about it. And look, if you can only help with 20% of the fatigue, often that's absolutely critical in releasing and giving you partial control. And you can work out, on a good day, you try to do too much, and you pay a price for the next few days. So you can work out how best you handle fatigue. Empowering patients exercise. You might have noted I had to leave the room when yoga was on the stage. And the point I'm making here is that you've got to understand exercise is not for everyone, and most of all, if you've got bad joint symptoms due to sarcoid, it's not a panacea. I've given you my personal views on exercise on the slide. I'm actually quite proud. I've modified Jerome K. Jerome, who said, work, work, there's nothing like work. I find that the word exercise fits the quotation rather better. But look, there's no doubt, in the right people, rehabilitation can help fatigue. Some people are able to train down their fatigue. For other people, that's a disaster. They actually just become deeply exhausted when they actually try to push exercise. So it isn't a one-size-fits-all. I think that there are general things, aren't there? So people, if you've got a good relation, are asking you, what can I do? How can I empower myself? I get asked about diet. Now, I can't advise people on diet. I can certainly encourage them to experiment, because I know, for example, some people will tell me they know that if they avoid dairy products, their sarcoid is better. If you want to experiment, it should be encouraged, and all you're really doing is endorsing people doing that. And most of all, the last point I'm going to make is the issue of stress. Now, I've made a point in listening very hard, and then asking questions, listening very hard. And what I'm convinced is that in sarcoid, and I don't see that in some other diseases, very commonly sarcoid develops at times of great personal stress. And secondly, very commonly, and not usually the same people, but sometimes, if you have symptoms that vary, they will be worse at times of stress. And this should not surprise us. The immune system is a barometer of everything about you. If you overwork and you're exhausted, you come down with infection. To me, it's logical that the immune dysregulation of sarcoid might be promoted by stress. And so I can't tell people how to de-stress themselves. What I can do is make them very aware that this is not some crazy idea or a problem they have, but highly plausible, and absolutely anything they can do to improve their own quality of life in general, even going to yoga, for example, is something they should actively explore. Now, I can't tell people to slow down because some people are more stressed if they slow down. Everyone's got to work out what they do. What you can do is empower people to know that they should do this and that this is not a deficiency of some kind, because stress is playing a role. So I'm going to stop at this point with some work points, and I've just stuck them in, but let me leave it at that and let's hear what you've got to say. But remember, that cat.
Other questions?
People are frightened of the cat.
You skipped over the slide, thank you very much, but you skipped over the slide about the acceptable or unacceptable fatigue. I'd really love to see it. If you
Which slide? Sorry.
It was the acceptable or unacceptable, I can't remember what it said, level of fatigue or...
I don't think fatigue is really acceptable. What I was getting at is there are side effects you feel you accept and you'd rather not have therapy, so that's acceptable loss of quality of life. You've accepted that and you've made a choice not to have therapy. I think you've absolutely got to explore fatigue, but I will go back to fatigue in that case. I did skip over slides for lack of discussion time. And to reiterate, I think the problem that most often matters to patients, I'm convinced, remains fatigue. There will be a lot of people here that this is exceptional to. They have a particular major organ involvement that matters the most to them. I'm making an average statement. Okay, now, you've got to understand fatigue, and people often mix it up with breathlessness. And you'll be told that you're exhausted and you can only walk 20 yards. But when you do a 6-minute walk test, people manage 400 yards, but they just feel exhausted. So often that's difficult to separate. You've got to deal with de-shaming fatigue, which is what I mentioned. But there's another key point that's worth making. You've really got to take it in your hands, and I believe you do this the first time you meet a patient, and you make the point that there are some questions you can't judge. You can't judge if they've got sleep disturbance. And I generally make a joke, I say as a young doctor, which is frighteningly long time ago, I thought I could look at people and decide they had depression, and boy was I wrong. So you don't wait, because if you get to know somebody and then you ask them about depression, you'll send a message that you're another of these people that's judging them and thinks that it's all in their heads. So you've really got to say, look, if you've got a nasty illness, the abnormal reaction is to be ecstatically happy. And basically, having unhappiness can drain your energy. But I always start with sleep disturbance and move straight from that to depression, and then ask them to put the package together. And very often, somebody will thoughtfully say, I think maybe sleep disturbance is a big deal, or I think, yes, maybe actually being very unhappy is probably contributing. But then we agree, usually, that the big deal is sarcoid fatigue, but you've got to think about these other things. So you've really got to do that, and I believe it's much better just to be upfront about it. I've never ever had somebody coming at me because I've raised that, because I've laid on the line that I can't make the judgment, but it might be very important. Okay, and this bit here is just an extension of that, that maybe steroids are not a great treatment for depression. Monitoring if somebody's on steroid, monitoring fatigue is difficult because if you reduce steroid, you temporarily will get fatigue. So if you think you're treating fatigue, you will be led to the false assumption that you need to go on with the same dose of steroid. It's very nice if you can get objective evidence of disease activity using one marker or another when you're thinking about fatigue, but sadly, I think more often than not, you can't. Okay, that was the bit I skated over.
Yes, I have a question. And thank you for this presentation on fatigue. It's a big deal with warriors that are suffering with it. My question is,
I think you need the microphone.
oh, I'm sorry. Yes, my question is, since fatigue is a major part of sarcoidosis, why isn't pulmonary rehab incorporated in the initial treatment plan for a newly diagnosed patient?
Oh, I think it should be considered, and I did make the point. Now, I joked about exercise because I feel a slight hypocrite at times trying to tell people they must exercise. And I did make the point that it really isn't for everyone. It's not a one-size-fits-all. And if you've got bad arthritis from active sarcoidosis, then going straight to rehab without addressing that is not a good idea. But I do think that you've got to encourage patients to explore exercise. But what I don't like is the messianic approach to exercise, that every person must exercise and that it is always the right answer. I think with all these things, you've got to work it out. There really isn't a one-size-fits-all, and the view of the patient as to what exercise is achieving is absolutely pivotal. I know this is slightly heretic. I'm supposed to stand up and say everyone should have rehab, everyone should exercise. All I can say is that patients, many of them don't actually agree with that. But many feel strongly that that's correct. So I think you've got to work it out.
I think that's it. Thank you so much, Dr. Moore.